we got all these things that we want to do with our patients. We got all these different ways of approaching our patients. And we want to build a scaffold. We want to build a framework that we can bring what we do to the table and organize it and execute a complete management approach with our patients. Often as manual therapists, we would address their pain and their dysfunction in a joint, a nerve, or a tissue. And other clinicians will address the inability of people to move. They'll address their strength, their endurance, their movement. And there's been a big argument in our professions about which one is the approach to treating a patient with low back pain. Should I use manual therapy? Should I use exercise? And we say it's not about which one, it's about when. It's about with whom, to what extent, how much, based on what understanding, based on what finding. And so what we've thought about is ways to organize that. And we say that we need to address all of this to different levels depending on how the patient presents, acute, recurrent, or chronic. All right? We're going to choose a different emphasis on their pain or their dysfunction. Their psychomotor control is jump-starting their effector system, their neuromotor control, the muscles, getting them to fire in the right way at the right time with the right sequence, the way quote-unquote normal people ought to move. And then the somatosensory control is balance, posture that's built on reflexes and built on proprioception. It's controlling movement using the sensory system to shape how we move. And then, of course, fundamental performance. We've been doing this since we were babes in our profession, right? We've been doing this from the start of our first lab in our school experience. That's strength, endurance, fundamental coordination, those kinds of things. But frankly, we've learned that strength and endurance are necessary but not sufficient for recovery. They're necessary. You've got to have cross-sectional area to hold yourself up against gravity. But it doesn't ensure you're going to move well. I'll never forget how, as a younger therapist, we were just entering into this dawn of learning how to integrate sensory motor control with manual therapy. One of my buddies saw this case that got rehabbed with another group in another part of New Mexico, but he went back to his home in Alamogordo, and he was asked, my buddy was asked to do the isokinetic test on this kid for return to play. So he did the isokinetic test, and the results showed 85% recovery of the involved side after ACL reconstruction to the uninvolved. And the kid said, well, the doc's going to let me go back to play if I'm over 80%. So he went back to the doc and said, this kid's not ready. He said, yeah, he is 85%. Yes, he is. But I asked this kid to stand up on one leg, and he was all over the place. And you're asking him to go back to play. He had the strength, he had his endurance, but he couldn't control. So strength and endurance are necessary, but not sufficient for recovery. So recovery involves many more aspects, not only how to orchestrate neuropsychomotor control and somatosensory control, but also on some clients, such as performers, how to engage in their advanced performance, their speed, agility, power, directional change. All those are going to be important. And finally, trying to plug all those skills into recovery. How people recover. Their functional advancement. Going back to the skill set that they were born to do or they're supposed to be doing. Sue Falsoni, our dear friend from Athletes Performance, says it well. She says, if my athlete needs to go here, stop, and turn, then I'm going to deconstruct and reconstruct them in their movement to take them back to that. Right? And so our functional advancement involves a systematic way to get them back to that movement. Let's plug it in with a pedestrian. I had a guy who his job was to pull the hose down and fill the oil up at one of those quick stops, right? And he had a lot of trouble with this because of his back pain. Well, as we took him through all of these different stages, we had to get him to the place where he could do that again. We had to have a systematic way to deconstruct that movement and reconstruct it and build all the foundations that led up to it, build a scaffold underneath him so he could do it, right? So we can start anywhere along this continuum, anywhere here, but where we start will dictate the directions we go. We could start out with a patient who comes in with a complaint over here and progress him. We could start out with a person over here who just wants to move better and then address those parts of this that we need to address. Some people may have seen one of my colleagues for getting rid of their pain and dysfunction, but their sensory motor system needs to be jump-started. So I may pick them up here and then carry them this way. So it's going to depend on when the client approaches you, how you're going to begin with them. But they could start anywhere. For example, if you have a patient that comes in with pain complaints, then we need to start somewhere. We need to screen this person and see if their pain complaints can be addressed by what we do. And there we're going to use a medical screen. That's about the practitioner of the 21st century, isn't it? The first contact practitioner, screening them for conditions that we may not be able to help. If we decide that we can help them, then we progress on with a clinical examination. We're going to do that this weekend, a clinical exam where we're going to identify those problems that we can address with our manual therapy approach. And from that exam, we make a structural diagnosis. The tissue is an issue. All right, then, from there, we choose to manage their pain and dysfunction. We're going to use a diagnosis-specific orthopedic manual therapy approach. And that diagnosis specificity, they could have a disc problem. We may choose to do one thing that's better, or one set of things better suited for a discogenic pain, another set of things better suited for sacroiliac. But we're going to choose a diagnosis-specific manual therapy approach. We're not going to do that manual therapy forever. We're going to, as we taper off, as they begin to recover in their pain and dysfunction, we're going to introduce more movement, more activity, and that's the wind in the sail. The manual therapy is going to redirect the ship, but the movement, the exercise is going to fill the sail to move the ship forward. And along the way, even on day 2 or 3, we'll start out with something, right as we're doing manual therapy, we'll start out with something to jumpstart the nervous system, jumpstart the locomotor system, right? Little muscle activation strategies. We're doing them. We'll see some of those things you're already doing, but we plug them in to get them jump-started. And then we might do some things on the somatosensory level, improving their balance, jump-starting their reflexes, doing those things that help to get the system primed. That is done diagnosis inclusive, meaning every diagnosis gets something. Now, I might adjust it a little bit based on how the person responds, but everybody's going to get something. Now, some of my clients with back pain, I may decide to progress them to functional examination. Now, a lot of my acute guys, I don't do that, all right, because what's one of the goals of our management with an acute patient is to try and get them in and get them out and get them functioning. Let them bypass or steer around recurrence, right? So I don't want to keep them there a long time unless they've got this history of poor movement behind them, they're not recovering well to what I'm doing, then I might plug this in. But a lot of our cases I'm not going to do this with. It's more the recurrence and the chronics that I use this for. On some of them I'll use it if they came in with their acute history but they also had other problems earlier, then I might choose to do that again to find out some underlying mechanical causes or contributing factors to their complaint. Here we're going to do a functional exam, a different set of tests, where I'm going to assess if the patient has movement dysfunction. I'm going to redirect my attention from structure to function, from tissue to movement, and I'm going to make a functional diagnosis about their movement dysfunction. And from that functional examination, I'm going to then construct a strategy or set of strategies that will help them change the way they move. We call those corrective strategies. Those corrective strategies will be specific to the findings we found in the functional examination. Now, the system will often implement either when they start to show about a 50% improvement, but they're not getting well, they're just getting better but not getting well, or many times what I'll do in my cases when I'm going to plug this in, I'll use this for my 30-day reassessment. It allows me to change at that second month of care. If the patient's made sufficient recovery and they're starting to show signs that they can go to that place, I'll use that as a way to document that I've changed my attention in management from structure to function. And you know that's what our payers are looking for anyways, right? They're looking for some obvious evidence that I'm changing my direction with the patient to get them back to a functional level. This is a great way to show that. And in my reassessment, I'll include a follow-up on the things that I assessed in my initial examination, and then also those things I'm looking forward to. So I look back and I look forward. I go from a tissue diagnosis to a functional diagnosis, structure to function. Now, on some of our clients, they need to perform at an advanced level. So I'll start putting things together that reflect speed, agility, power, directional change, multi-joint system movement responses. And there we use composite training where we're doing landing and cutting and all those types of things we like to use to help our performers change the way they move. So I might take them to that place as well. And all of these things encompass what we do in Semacore. We take people from this place and move them to this place. We take them from a structural, where we're leaving off on a structural management model, to a functional management model. Now, some of my clients will come to me wanting to simply enhance their performance. They don't have a complaint. They'll come to me saying, I want to move better. I want to compete better. I had one guy who's a cyclist that came and said, I melt in the fast break. He'd get dropped. And if you look the way, he had arms of iron, legs of steel, and trunk of mush. And what would happen is, right at that fast break, when he started seeing the heads bob in the front of him, he knew that the whip was about to crack. He couldn't build his power up fast enough to get him to the place where he could respond. We took him through the functional exam, put him through some corrective strategies, went to some composite training, and improved his power about 20% in that fast break response. And this is a Cat 3 guy. I mean, he was already performing right under and above his anaerobic threshold, but he was able to improve that power transfer. And those guys that work with those kinds of athletes, you know that's true. You change the way they control their trunk, it changes the way everything works. You can change the way people pitch a ball, the way somebody swings a racket by changing the way they control this. And so that's the type of management strategy we may want to go with. But if they come to me wanting to enhance their performance, instead of using a medical screen, they don't have a complaint, instead of using a medical screen, I'm going to use a functional screen. And the functional screen I like to use is the FMS according to Greg Cook. I don't use that on everybody. I use it on those people that want to enhance their performance. Yeah, my pedestrian, Miss Jones, keeping HIPAA in mind, of course. Miss Jones, she may not, she's not going to move in a performance way, so the FMS is not appropriate for her. But for those people that are going to perform, on them, I'm going to do the FMS. For Miss Jones, if I want to take her to a higher level of movement, she's got persistent symptoms, she's not responding completely the way I want her to after an acute event, then I might choose to do some parts of the functional exam with her. All right? But with my performance client, I'm going to use the FMS, and according to their score, it's going to determine which direction I go with their management. If they come and score over 15, we might direct them to sport-specific training. If they still have issues in their movement, I might shift them to a functional exam. But if they score under a 15, then I'm going to direct them to the functional exam. And then approach their rebuilding, their reconstructing their movement with corrective strategies. If they get a 0 in any one of their tests, it tells me to take them to a clinical exam. Because I haven't seen them before, I don't know about a complaint, and if they have a complaint during the FMS, that's like, maybe there's something going on underneath all this that's keeping you from performing well. Then we take them to the clinical exam and take them through that process I described before, you see. On the other hand, if they don't have a 0 on any of the 7 tests of the FMS, then we take them to a functional examination and assess their movement. Now, and then I take them through the process again. And we can use the FMS as a metric to decide when they might go from a clinical examination to more movement. For example, you've got an athlete that comes in. They've developed a soft tissue problem. Their doc and their coach are wanting to get them back to the field. You're saying, oh, no, I don't think they're ready yet. And they're saying, yes, they are, let's get them back. Well, do an FMS on them. If they score under a 15, then you can say they have a higher risk of injury if they go back right now, let's first work on the quality of their movement, then take them to the clinical exam, the functional examination, then take them to the movement training, the sport-specific training, you see? So it's another little stepping stone you can use to assess their readiness for the next step. And finally, along the way, we're going to use good biopsychosocial assessment skills. So depending on which category, acute, recurrent, or chronic, they fall in, I'm going to use different skills, right? As Kelly suggested earlier, I may want to really work towards helping my client redirect their attention from the fear of the unknown to confidence. Don't be scared, just be prepared. Help them change their attention to how they attend to this problem. With a recurrent caseload, help them develop courage and persistence in their recovery process, because often they get worn out. They get tired of dealing with it. It takes consistency. It takes commitment. We say it takes a belief in the need to recover. It takes a commitment to the recovery process, and it takes a relationship with someone to help them. Those three ingredients are critical to the recurrent patient's recovery. And then on the chronic caseload, there's many biopsychosocial interactions we have to attend to. And there are skill sets on how to address that. And we offer coursework in the IOM to do this. We have coursework that can teach you a systematic way to develop skill sets in dealing with those really tough cases, helping them to change their belief system about their experience, helping them to develop self-efficacy, helping them to develop greater confidence in your ability to help them redirect their recovery. And with that, we use management strategies. We have assessment tools to understand how they are responding on the biopsychosocial level and how we can manage them on that level. And that's our coursework aimed at biopsychosocial recovery. Okay? So all of these things lend us to a comprehensive scaffold for management. And let's say you say, I do a particular approach to this type of tissue response in my manual therapy. We ask ourselves, where does it fall in place? Where does it fit in that scaffold? I use a particular approach to patient response and movement. How can you make it fit to see it fit in the bigger picture? This can help you get your arrows organized in your quiver. So that's all I have to say about this right now. We'll bring it back to the table as we go along. It's a scaffold. It's a way to organize our approach. Are there any questions, comments from the first session, the first discussion? What does this conjure up for you? What does this bring to your mind?
Assessing the patient's goals and what they want, what their functional outcome they want.
Assessing them for their functional outcome, what they want. That's right. That can be a great way to organize how to educate your patient about what you're going to do. I'm going to address this, this, and this, this, and this. And this is how we're going to go through it. Each one of our colleagues in the clinic have a large color copy that's laminated of the slide on their desk, pasted on they have a window in front of their desk looking out in the gym right there. And then they have another copy they can use to educate their patient. We use the slide as a dynamic tool to help remind, especially my younger colleagues, to not leave something out, to help them organize their thoughts. Because the way the brain works, John says this well, he always says, you're creating new synapses. And every time you look at something, yourself as a clinician, every time you look at something, every time you remind yourself, every time you tell yourself to be mindful of something, it creates new synapses. It helps you think of other ways in which you can approach something or tackle something or solve something. So for my colleagues, the slide's been very helpful because it helps them be mindful of all the things they need to attend to, and a way to get their brain organized and to create those new synapses in their systematic approach with their patient. Because often what colleagues do, it's 4 o'clock on Thursday afternoon, they got 4 cases in in the clinical domain, doing different things with them, trying to work on them. None of them Medicare, of course, but they're all being managed, right? And so what a colleague is at the risk of doing is saying, okay, what am I going to do with this patient for exercise? Okay, and they'll immediately, it's human nature, go to what they did with the last case, right? So, okay, I'll do this. Yeah, Ms. Jojo, and they don't have that scaffold to build their decision-making on. And so what this does for you, there's different tools in the system that allow you to check things off and go, okay, I did that, and I can do that. Good. They don't have to go, you don't have time to do that, right? That doesn't work. As our demands get greater in the clinic, time shrinks with our patients. We need to have more efficient ways to jumpstart those synapses, to be creative and systematic with our patient. And that's what we want to provide for you, is that scaffold. Cool? Yeah, Terry.
What do you mean by functional advancement? Why is that at the end of the continuum?
Functional advancement means, because the reason it's at the end, it's not at the end, it is the next step, and you can be encouraging different parts of it as they go along. In other words, I might be working on functional advancement here on one particular movement domain, and I haven't gotten there on another one. What that means is, let me give you a case example. I've got a guy that comes in with recurrent low back pain. He first gets his manual therapy, L3-4, and for moving, for helping them recover in dysfunction, and L4-5 for pain control, right? At the same time, I'm treating his hip for hip extension limits. And he's doing neural flossing, and he's doing hydration management. I'm going to fill his sail first with a fundamental six-pack to get his muscles started. That's early on. And I'll get him to start doing some balance stuff and some reflex reactivation at home, okay? Then what I'll do as time goes on, he starts to recover, then I'll do a functional exam. And on him, I'm just going to pull this out of the air, okay? He had rotatory control dysfunction and extension control dysfunction. Those are the directions of control dysfunction he had. So I'm going to give him corrective strategies to help address that, all right? He happens to be a policeman who works on the east side, and he has to jump over a lot of stuff. He's chasing people all the time. Not every day, but chasing is a function that he, having to jump and crawl and hurdle, do all these different things. Then what I'm going to do is choose composite training that builds control in those directions of movement that he has a challenge with at work, based on my relationship with him, learning that those are the things that are hard for him, right? And at the very end, his functional advancement is going to an environment where he's going to have to perform that exact skill that he has to do in work. So it's deconstructing what he has to do and then reconstructing. The reason it's at the end, it's a reflection on taking apart his movements, working on the parts, and then reassembling them into his functional advancement.
I get it.
Do you get it? That's what that means. That's an example. That's the one patient we saw. I had him doing crawling and rolling and jumping, doing what we call horizontal composite training, because he has to leap over creek, the little ravines and stuff on the east side, because it's kind of bohemian on that side of town. They don't have a lot, the dirt roads and all that stuff, on the far reaches. And he's chasing guys, he's apprehending guys and having to jump over stuff. So we had to teach him how to do that again, in context with control. Oh, he was doing it. He was recurrent. He didn't quit his activity, but every time he'd go home at night and just killed him. So we had to teach him how to do it. We found rotatory and flexion or sagittal plane control dysfunction on him. So we did his corrective strategies to fix that part, those building blocks, and then put them together into composite agility training, and then finally had him do that stuff and test it out. Do you follow? Mm-hmm. Did that answer it?
Yep.
Good. Anybody else? You guys are doing some of this stuff. I'm confident of that. That's what we do. We're movement specialists. This is a scaffold to help you get it organized. And plus, what we found as well, and I won't spend a lot of time on this, I'll talk a little bit more on Sunday, but I may choose composite strategies that are in the direction, I may choose like agility training that's in the direction of what I found was compromised in the functional exam. I could do it all, but time's money. So I really can focus on those things that I found in the functional exam are most troubled. You see, that functional exam ends up allowing us to create that organization to why we do what we do. Instead of saying, well, I think I'll have you do this, 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 and this. Why did I make that choice? I may have made that choice because that's what I did with the last guy, and it looked good, and they did well. But that may not be what the patient needs, you see? And there's tons of evidence. Our lumbosacral 7-core course has 260 references. And that's stuff that's been published since year 2000. There's a lot. And there's evidence for doing this, for doing it this way. We also teach people how to control the trunk during those transitions. And there's evidence for that too.